Have you ever seen two persons with the same BMI but one is obese and other is very muscular? Or the person is having normal BMI but still carries a high risk of diabetes and cardiovascular disease? So here is the important question: is BMI enough to assess the nutrition and the obesity? Hello everyone, welcome to Community Medicine Insight. In this video, we will understand about the basics of BMI. What is the difference between global and Asian classification? How do we assess the BMI in children? What are the limitations of BMI? And what additional measurements are required for the complete assessment of a person? BMI is Body Mass Index. Originally, it was known as Quetelet Index based on the name of inventor, who is a prominent Belgian mathematician and statistician. This indicator is used to assess the nutritional status and obesity. It relates a person's body weight to their height. So its formula is weight in kg, which is divided by the square of their height in meters. For example, if a man has a weight of 70 kg and his height is around 1.75 meters, then it is calculated by 70 divided by 1.75 and its square, and it comes around approximately 22.9. BMI is important because it is universally accepted, it is easy to calculate, it is non-invasive, it is also a cost-effective tool as it doesn't require any expensive equipment, making it very useful both in the community setting as well as in the hospital settings. Thus, BMI has several important uses, like for the screening of obesity, nutritional assessment both at the individual level as well as population level. BMI is also helped in the assessment of risk of non-communicable disease. It is used in various surveys, research methods, and also for the monitoring of obesity trends across various populations. It is also useful for the assessment of fitness and health monitoring programs. This slide shows two classifications for BMI. This is WHO Global Classification and this is Asian Indian Guidelines for the BMI. Less than 18.5 is being categorized as underweight in both the categories. But here we can see that overweight begins at 25 and obesity at 30 in case of WHO. While in the case of Indian, the overweight it starts at 23 and obesity starts at BMI more than 25. Lower cutoff are recommended for Indian because they tend to develop metabolic complications at a lower BMI level also. Asian develops metabolic disease even at the lower BMI when compared with the Western population. They have a higher body fat percentage even at the same BMI. This is known as a thin fat Asian phenotype. A person may appear thin externally but still may have a high body fat and metabolic risk internally. It happens because of the accumulation of visceral fat around abdominal organs, and that also leads to central obesity. Therefore, they have increased risk of diabetes mellitus, hypertension and cardiovascular disease. As we have seen in the earlier slide that there is a clear cutoff for the classification of undernutrition, overnutrition or normal BMI. But the interpretation of BMI in children differs from adults as their BMI will depend upon their age, gender and growth pattern. Therefore, rather than the fixed cutoff values, we are using here percentiles and Z-score for the assessment. So, we have CDC BMI charts and WHO BMI charts for their assessment. This is the WHO BMI for age chart for girls. On x-axis, the age is plotted and on y-axis, we have a BMI in kg per meter square. If the BMI for age is below 3rd percentile or less than -2 standard deviation, that is below this line, then it is being classified as thinness or undernutrition. If the BMI for age falls between 3rd to 85th percentile, it is normal weight. If the BMI falls above 85 percentile but less than 97, it is overweight, and above 97, it is obesity. This is the WHO BMI for age chart for boys, which is blue in color. The interpretation is same. If the BMI for age is less than 3rd percentile here, it is thinness or undernutrition. From 3rd to 85th percentile, it is normal weight. From 85th to 97th percentile, it is overweight. And above 97th percentile, which is more than 2 standard deviation, it is being classified as obesity. The BMI useful, it has various limitations. It does not measure the body fat directly, and therefore it cannot differentiate between that this weight is due to fat mass or this weight is due to muscle mass. Therefore, two persons can have same BMI even if one is overweight and other have a muscular male fit body, because here the weight is due to muscle and here the weight is due to fat. Second is, it does not assess the fat distribution. Why this point is important? Because visceral fat carries particularly greater metabolic risk, and it is less accurate in elderly, athletes, pregnant women and children during growth spurt. As we have seen, in athletes they have a higher muscular mass, therefore it may not be accurate. In elderly, what happens with the age? Decrease in muscle mass and there is increase in the fat percentage. So even if the BMI is normal, the person may be still carrying higher amount of fat and increased health risk. In pregnant women, it cannot be accurately measured because of the weight is increased due to fetus amniotic fluid. It may be less accurate in the children during growth spurt, because in some children there may be first increase in the height and later on weight increases, or in some children there may be first increase in the weight. Therefore, the BMI may be misclassified. To overcome the limitations of BMI, additional anthropometric measurements are required for the complete assessment. One of them is the waist circumference. It is a direct surrogate marker for visceral adiposity. In South Asian, waist circumference above 90 cm in men and above 80 cm in women indicates increased metabolic risk. Waist to hip ratio is another useful indicator. High risk is defined as more than 0.90 for men and more than 0.85 for women. For direct adiposity measure, we can use DEXA scan or bioelectrical impedance analysis or the measurement of skin fold thickness. DEXA scan is a dual energy X-ray absorptiometry in which a low dose of X-ray are used to measure the body composition. It can measure the total body fat, lean body mass, bone mineral density, regional fat distribution, as well as the visceral and subcutaneous fat. Its advantages include it's highly accurate and reproducible, and it's a gold standard for the body composition assessment also. It can differentiate between fat mass, lean mass, and the bone mass. But limitations are it is very expensive, it requires a specialized equipment, it exposes to a small amount of radiation. Therefore, it may not be practical for large-scale community screening. In bioelectrical impedance analysis, estimation of body composition is done by passing a small painless electrical current throughout the body. And the principle is based on the fact that the muscle contains more water and therefore conduct electricity easily, while the fat contains less water and resists the electrical flow. It can also measure body fat percentage, lean body mass, total body water and the muscle mass. Advantages include its quick, non-invasive, portable and relatively inexpensive when compared with the DEXA scan. Limitations include it's less accurate when compared with the DEXA scan. It may be affected by the hydration status, recent meal, exercise, menstrual cycle or the temperature. Accuracy decreases in very obese or very lean individuals. To conclude, BMI is a simple, practical, widely used screening tool. It is not a diagnostic tool. BMI alone is not sufficient for the obesity assessment. A comprehensive evaluation should include the BMI, waist circumference, the clinical examination of the patient, and the assessment of various metabolic risk factors. Because particularly in Indians, the lower BMI values may still indicate increased health risk.